All right, so today we're going to go over some basic anatomy with CT correlation. So in terms of the routine views, so the PA chest X-ray is the basic standard view, and it's done with the patient facing the image receptor. The X-ray beam goes from posterior to anterior through the patient. That's why it's called a PA, posterior anterior chest radiograph. We do that because that brings the heart closer to the image receptor, which minimizes magnification of the heart. We also ask the patient to put the hands on the hips or rotate the shoulders forward, and that helps to get the scapula off of the lung fields. The lateral chest radiograph is taken with the left side of the patient closest to the image receptor. Again, it's to minimize magnification of the heart since the heart is on the left side. So the X-ray beam goes from right to left through the patient, and we ask the patient to lift their arms to get the arms off of the lung fields on the lateral chest radiograph. So here we have two radiographs on the same patient. There's no pathology, but as you look at these images, you should be able to discern a difference between the two. What's the difference?
AP, PA.
So how do you tell the difference between an AP and a PA? Yeah, so if we look at the scapula, we see here that this is a nice quick way to do it. We notice that the scapula here are on the lung fields, and here they're rotated away from the lung fields. Also, the quality of a PA chest X-ray usually is also better than a portable AP view, especially. So, but if you look at the scapula, it's a nice quick way to determine whether you're looking at a PA or an AP view, okay? So with the PA chest X-ray, it's taken with the X-ray tube further away from the patient, and that also helps to minimize the magnification of the heart. With the AP view, and especially with a portable chest radiograph, the X-ray tube is actually closer to the patient, and the geometry here shows you that that gives you even more magnification of the heart. Now, you do need to know the formula for determining the amount of magnification in radiography, and that's simple geometry. So the magnification factor is the source image distance divided by the source object distance. So here with a PA radiograph, the source image distance is large, and so is the source object distance, so that the magnification factor is small, and contrast that with what happens with an AP view, that does give you magnification. So that's the physics of why we get magnification. So that is something they do ask you. Now, you do need to know the approximate radiation doses for each of the following. So first of all, what gives you a higher dose? Lateral chest X-ray or a PA chest X-ray?
Lateral.
Yeah, the lateral gives you a higher dose, and so often in pregnant women, if they get a chest X-ray for tuberculosis, we omit the lateral view, we just get the PA view. And as far as a chest CT, how many chest X-rays, what's the equivalent? So one chest CT is equivalent to about how many chest radiographs?
100.
It's about 100, right? So that's the number to remember. So a PA chest X-ray gives you 0.02 millisieverts, a lateral chest X-ray 0.04. We combine them, we get 0.06. And a chest CT is about 8 millisieverts. So one chest CT, as a rule of thumb, is about 100 chest radiographs. To give you comparison, the natural background radiation is 3 millisieverts per year, so that's what you get just living your normal life. And something we don't think about, but if you take an airline flight cross country, that's a dose of 0.04 millisieverts, about the same as a chest radiograph. Again, this is something people don't think about when they get on an airplane, but they might get overly concerned about the radiation dose from a chest radiograph.
And where does that radiation come from?
Cosmic rays, just getting up further in the atmosphere, so you don't have the atmosphere filtering out the radiation.
Nice.
Okay, and actually, airline stewardesses, they carry those badges to monitor their radiation exposure.
Nice.
These are terms that you need to be familiar with, and we'll cover these. So as a study guide, make sure you know about all of this, what each of these mean, both on the PA and the lateral chest radiograph. So the point of this conference or this talk is that you should be able to look at this chest radiograph, tell me what's abnormal, and also be able to tell me what tests should be done next. On this chest radiograph, you should be able to look at this and tell me what's abnormal and what you would recommend next. Same here, you should be able to not only tell me the abnormality, but also provide a specific diagnosis just from looking at the chest radiograph. So hopefully by the end of this talk, you will you will have acquired some of those skills. If I tell you this patient has fever and back pain, you should be able to look at the radiograph, tell me what's abnormal, have some idea of what the diagnosis might be, and suggest what service you might want to consult next for this particular patient. So starting with the mediastinal anatomy, the border-forming structures of the mediastinum, as we go around, what is this guy over here?
SVC.
That's the superior vena cava. Over here we have right atrium, right? This guy over here is,
Interlobar.
that's the interlobar pulmonary artery, okay? And on the left side, this is the left interlobar pulmonary artery. Now here we have three bumps here, these three mediastinal moguls that are roughly about the same size, and you do have to know what these are, and you should carefully look at these on every chest radiograph. So the first one is,
Aorta.
yeah, that's the aorta, that's the aortic knob here. The second one,
Pulmonary.
main pulmonary artery, right, and the third one here
Appendage.
of,
Left atrial.
that's the left atrial appendage, right. And below that, the rest of this border is made by the left ventricle. So another quick way to find the left atrial appendage is you look at the airway and where the airway ends, right there over the heart shadow, just below that is the region of the left atrial appendage, okay? So here it is with a diagram, superior vena cava, right atrium, aorta, main pulmonary artery, left atrial appendage, and the rest of that border is the left ventricle. And then here's a nice coronal CT, also showing you the anatomy here, superior vena cava, right atrium on the left side, aortic knob, and pulmonary artery, left atrial appendage here, and the rest of the border here is the left ventricle. Most of the time, that right border up here is the superior vena cava, but if you have a tortuous ascending aorta, or if you have an aneurysm of the ascending aorta, sometimes this border can be formed by the ascending aorta. In this case, with atherosclerotic disease and a tortuous aorta, you can see how that border is formed by the ascending aorta in this particular case. All right? So having gone through that, if we look at this chest radiograph, what is wrong when we look at the mediastinal moguls? You would tell me what? Yeah, so the main pulmonary artery here especially is enlarged. We have the aortic knob here. Here's the main pulmonary artery, left atrial appendage. We have an enlarged main pulmonary artery. Also, you mentioned that the right pulmonary artery is also enlarged. And also back here, we can see that the left pulmonary artery also looks enlarged. So for this patient, we would consider what? Yeah, so pulmonary artery hypertension. If we have enlargement of the central pulmonary arteries, we need to think about pulmonary artery hypertension, and that's the case there. So later on, we'll go through the differential and the approach to pulmonary artery hypertension. Now contrast that with this case. When we look at this case, what is enlarged here?
Just the left.
Yeah, so the main pulmonary artery here is big, and the left pulmonary artery is big, but the right pulmonary artery is
Normal.
normal. So what does this mean?
Pulmonic valve stenosis.
Pulmonary valvular stenosis. So if we have enlargement of the main and the left pulmonary artery, but the right pulmonary artery is normal, we think of pulmonary valvular stenosis. And the reason this occurs, this configuration, is that the poststenotic jet with pulmonary valvular stenosis results in enlargement of the main and the left pulmonary artery because the left pulmonary artery is continuous with the main pulmonary artery. The right pulmonary artery comes off at an angle, so the right pulmonary artery is not enlarged. So if you have enlargement of the main and the left pulmonary artery with a normal right pulmonary artery, here we think of pulmonary valvular stenosis. Now, in cases of pulmonary valvular stenosis, what is the pressure in the pulmonary artery? Is it increased, normal, or decreased?
Normal.
It is normal. Yes. So the obstruction is at the level of the pulmonic valve. So the pressure in the pulmonary artery is actually normal as the right ventricle hypertrophies to maintain the perfusion. The pressures in the right ventricle are elevated because of the obstruction at the level of the pulmonic valve, but the pressure in the pulmonary artery is actually normal. All right, so that's the configuration for pulmonary valvular stenosis. Now, the vascular pedicle is this area over here, and we need to be familiar with the contours of that. So the right border of the vascular pedicle is made up of
SVC.
SVC. The left border of the vascular pedicle is Left subclavian artery, right. So the right border of the vascular pedicle is a venous structure, so you can get enlargement towards the right if you have increased intravascular fluid, increased central venous pressure. The left border of the vascular pedicle is made up of an arterial structure, the left subclavian artery, so you can get enlargement to the left if you have atherosclerotic disease, if you have an aneurysm, systemic hypertension. These are things that can give you enlargement towards the left side. This is the same patient. Here there's widening of the vascular pedicle because now the patient has increased intravascular fluid and some pulmonary vascular congestion, and the superior vena cava here widens towards the right. So the vascular pedicle, the right border is the superior vena cava. The left border up here of the vascular pedicle, that is the left subclavian artery. So venous structure on the right, arterial structure on the left. So that's your vascular pedicle. Now this patient, this is that patient with increased intravascular fluid. You can see there's distension of the superior vena cava towards the right, as you see here, because of the increased intravascular fluid and pulmonary venous congestion also in this case. This oval-shaped structure also distends when the central venous pressure is elevated or there's increased intravascular fluid. What is this oval-shaped structure over here? Yes, that is the arch of the azygous vein as it travels forward to join the superior vena cava. That can also dilate if you have elevated central venous pressure. So the azygous vein travels up here in the superior mediastinum, arches forward to join the superior vena cava, and where it's arching forward, we see this oval-shaped opacity. That is the arch of the azygous vein. So notice that you can see the superior vena cava here and the right paratracheal stripe and the azygous vein there on a nice PA chest radiograph. So what could this arrow represent? What could that be?
So the azygous?
So that could be a dilated azygous vein. Is there anything else that could be?
Lymph node?
Yeah, so that could be lymphadenopathy, right? So we have a right paratracheal mass here. It could be lymphadenopathy. It could be a dilated azygous vein. Since we just talked about the azygous vein, what are causes of dilatation of the azygous vein? So azygous continuation of the IVC is a congenital variant that can result in dilatation of the azygous vein. What else? So volume overload, increased intravascular fluid, SVC syndrome, right? So the azygous vein acts as a collateral, so obstruction of the superior vena cava or obstruction of the inferior vena cava can also result in dilatation of the azygous vein. Portal hypertension, again, because it can be a collateral route for the portal venous blood. So those are some causes of dilatation of the azygous vein. Also, anything that increases your central venous pressure might also dilate the azygous vein. So here in this patient, here's the aorta on the left side. Here on the right side, we see this dilated azygous vein coming up, arching forward, and that's where we see this right paratracheal opacity there. And then here's CT images on this case. Here's the dilated azygous vein coming up here, arching forward to join the superior vena cava. So why does this patient have a dilated azygous vein?
Continuation of the...
So this is azygous continuation of the IVC. How do we recognize it as azygous continuation of the inferior vena cava?
The liver.
The intrahepatic inferior vena cava is absent, right? So absence of the intrahepatic inferior vena cava is the hallmark of azygous continuation of the IVC. So what happens to the hepatic veins? Stumped. They form a smaller IVC. See that? That's this guy over here. So the hepatic veins do form an IVC that drains to the right atrium, but the intrahepatic portion of the IVC is not there. So all of the venous return from the lower part of the body is coming up through the azygous vein here, which essentially replaces the IVC embryologically in these cases, and you get this dilated azygous arch, which we see on the chest radiograph as the dilated azygous vein. Okay. What is the arrow pointing to?
Superior intercostal.
So otherwise known as the aortic nipple, right. So the aortic nipple is this round structure here that we can see next to the aortic knob, and anatomically that's made up by the left superior intercostal vein. So remember on the right side we talked about the azygous vein arching forward, joining the superior vena cava. On the left side, you can have the left superior intercostal vein here as it arches forward to join the left brachiocephalic vein. And if it happens to run parallel to the aortic arch, right, that gives you the aortic nipple on your chest radiograph. Okay, By the way, this structure over here, that vein, what is that vein? Accessory left hemiazygos, yes, that is the accessory left hemiazygos.
Accessory hemiazygos?
Yes, that is the accessory hemiazygos. So, aortic nipple here, that is the left superior intercostal vein as it's arching coming forward, parallel sometimes in some patients, to the aortic arch to join the left brachiocephalic vein, okay? When we look at the normal hilar, the hilar should be smooth and vascular. There should be nothing bulging out from the hilar on a chest radiograph. So we talk about the hilar angle here. So we have vessels here. Here's the interlobar artery. There's this vessel here, which is usually the right superior pulmonary vein. This is the hilar angle in here. Notice that it is very smooth. You should not have anything bulging out. Here diagrammatically, superior pulmonary vein, interlobar pulmonary artery. There is the hilar angle. Nothing should be bulging out from that region. Very similar on the left side. Hilar should be vascular and smooth. You should not have anything bulging out from the hilum. So here we have the right pulmonary artery that goes across here, anterior to the right upper lobe bronchus. So the left pulmonary artery goes up and over the left upper lobe bronchus. Now there's a particular word that they use to describe the bronchus that can come up on exams. You know what I'm talking about? When the pulmonary artery goes either above or below? What is the word? Which eparterial bronchus and hyparterial bronchus, right? Which one is the hyparterial bronchus? Right or left?
Hyper?
Hyparterial bronchus. Which one is the hyparterial bronchus? The left. It goes under the pulmonary artery. The left is the hyparterial bronchus. The right is the eparterial bronchus. So that term may also come up on your exams, which is the hyparterial bronchus, which is the eparterial bronchus. Okay. So here we have then the right pulmonary artery coming across, dividing into the interlobar artery, and then the branch to the right upper lobe. Here's the right superior pulmonary vein coming down. Here's the hilar angle in here. Notice that it is nice and smooth. Nothing should be bulging out from the hilar angle. There is another term that can be used for the right upper lobe pulmonary artery. Do you know what that term is?
Truncus anterior?
Truncus anterior, yes. The truncus anterior is the right upper lobe pulmonary artery. Okay? So, when we look at this radiograph, is there anything that bothers you?
Convexity at the right hilar angle.
So when we look here at the right hilar angle, maybe there's something bulging out here. Now, the radiologist's best friend is prior films. So it is important to compare with prior studies. By the way, the only thing better than old films is future films. So
As correlated to the future film.
that's right. So often, I mean, when you're reading a portable chest X-ray, you might have an X-ray that was done 3 hours later or 6 hours later.
Dr. Mo, just in case, there's some settings that really don't like that, just so you know. You know, when you're not covering chest.
The information is there, use it.
Okay, all right. I told them Dr.
This
Mellon
job is hard enough. Cheat any way you can. Okay? All right. So when we I want that third alternative. Those of you could tell me about that episode. When we compare, we notice that here the hilar angle is nice and smooth, but here there is a subtle bulging. So this is where comparison with the old films can be very useful. So what do you suspect this might be? Lymphadenopathy, we would recommend CT with contrast, right? So here's right hilar adenopathy, in this case, some right hilar nodes. This was a patient with lung cancer. Very subtle on the chest radiograph, but comparing with the prior films can really help you. And, especially if you question an abnormality, a subtle abnormality like that, okay? The bronchial anatomy. You do need to know the bronchial anatomy, the segmental anatomy very well, especially on a CT. You should be able to point to any image on an axial CT scan, point to an airway, a segmental airway. You should be able to tell what it is. The appearance of the airways on the CT, since we're looking at axial images, depends on their orientation relative to the axial cut. So the trachea, you will be cutting in cross-section, that will appear round. The right upper lobe bronchus falls in the plane of the scan, that will appear tubular. The bronchus intermedius you'll be cutting in cross-section, that will be round, and so on. Same thing with the lingular bronchus and the right middle lobe bronchus, they tend to fall within the plane of the section. So the bronchial anatomy we need to know. So here we have the trachea. Coming down here, we have the right and the left main stem bronchus. When we go down lower, this guy over here is the right upper lobe bronchus. How many segments to the right upper lobe? 3, and they are apical, anterior, and posterior. Right. So here's the anterior segmental bronchus here. Here's the posterior segmental bronchus here. The apical bronchus goes straight up. So if you go up just a little bit, you will see the apical bronchus, and you'll be cutting it in cross-section. This vessel over here, what is that vessel between the anterior and posterior segmental bronchus? That's a branch of the right superior pulmonary vein. Almost always, that's going to go down into the right superior pulmonary. The pulmonary artery is usually here, anterior to.
What vessel did you say it was again?
It's a branch of the right superior pulmonary vein. You follow that down, and it'll join the others to form a nice right superior pulmonary vein. Okay, but it tends to be right there between the anterior and posterior segmental bronchus of the right upper lobe. So here's the right upper lobe bronchus there on this coronal image. There's your apical segmental bronchus going straight up. Okay. Now we go down lower, we get to the bronchus intermedius over here. Okay. So the bronchus intermedius eventually will supply the right middle lobe and the right lower lobe bronchus. That's why if you're reading a chest radiograph, a portable chest radiograph, and the right heart border is lost and the right diaphragm is lost, you think about mucus plug where? Causing atelectasis of middle lobe and lower lobe. Yes. Okay. The right middle lobe bronchus, when we go down lower, here's the right middle lobe bronchus. The segments to the right middle lobe are?
Medial and
Yes, so lateral and medial. Lateral, in terms of the numerical scheme, comes first. You have lateral and medial there, okay? And the lingular bronchus is usually very close to the same level as the right middle lobe bronchus. Now, the superior segmental bronchus, when we get to the lower lobes, comes off first, and then you get this guy, which will branch into the basal segmental bronchi. So this guy is called the truncus basalis. So from here, you will get the basal segmental bronchi. And what are the basal segmental bronchi for the right lower lobe? Medial, anterior, lateral, posterior. You can remember that because Malp, and it's very close to my name. So do not forget this. Right?
Malchin.
With a P. All right, so superior segmental bronchus, truncus basalis, the medial comes up first, then you have the anterior segmental bronchus, and then posterior, the lateral and posterior segmental bronchi. Okay, so you should practice on a CT scan, going through it, on the axial images, practice naming the segmental airways. For the left side, in most cases, the left upper lobe bronchus trifurcates. Remember, there is no middle lobe on the left side. So the left, this left upper lobe bronchus here will give you the lingular bronchus also. So it bifurcates in most cases to a superior trunk, and then that superior trunk will give you an anterior and an apical posterior segmental bronchus and a lingular bronchus. Right? So left upper lobe bronchus, you get a superior trunk here. And then from there, you can get an anterior and an apical posterior segmental bronchus. And then here, you will have the lingular bronchus. So left upper lobe bronchus, superior trunk, and then as we're going higher, you get the apical posterior and then the anterior portion here. When we go lower, then you get into the lingular bronchus. Okay, so on the left side. So that's where the left side is a little bit different. Now, the basal segmental bronchi are pretty much the same, except you in the most common variant is to have an anteromedial combined bronchus here on the left side. So superior segmental bronchus, truncus basalis, and then you have this anteromedial bronchus that comes off, and then that divides into the medial and the anterior, and then you will have the lateral and the posterior segmental bronchus on the left side, right? So that's the anatomy for the basal bronchi. Again, it's important to practice this, go through an axial CT scan, try to name all these segmental airways, right? So that's basic stuff that you should know at this point on the chest rotation, or just in general. Here's a nice example: medial, anterior, lateral, posterior there on the right side. Anteromedial here, lateral, and posterior on the left, right? And medial, anterior, and then here as we come down, lateral and posterior, okay? Okay, what is that line?
Junction.
No,
No, wait, that pleural esophageal.
that is the pleuroesophageal line, correct. So if there's some air in the esophagus, you might see the right wall of the esophagus superimposed on the trachea. The right paratracheal line is here, okay, a little bit further to the right. That is air in the esophagus outlining the right lateral wall. That is the pleural esophageal line. Okay, so here's the esophagus, air in the esophagus outlines the right wall over the trachea on the chest radiograph. So don't let that fool you. Okay? What is the arrow pointing to?
The left,
The left major.
That is the left major fissure. How do you know that's the left major fissure?
Because
I
it's
just-
going towards a diaphragm that I can't see.
That's right. It's going down to the left diaphragm. So the right diaphragm you can see through the heart shadow. The left diaphragm disappears where you get to the heart. That's how you differentiate the right and left diaphragms on the lateral chest radiograph. So the left major fissure here comes down to the left diaphragm. The right major fissure comes down to the right. Also, the right major fissure usually inserts more anterior than the left major fissure. What is that?
Superior accessory.
That is a superior accessory fissure, right. So that separates,
Superior, not up.
yeah, that's the superior segment of the left of one of the lower lobes. Here's the right lower lobe from the rest of the lower lobe segments, right? This guy over here is minor fissure, and then this guy would be major fissure, right? Okay. This guy, that is the inferior accessory fissure. So that separates, yeah, the medial basal segment from the rest of the lung. So here's the inferior accessory fissure here on a coronal CT scan. And there it is. Sometimes you can see that also on a chest radiograph. That's the inferior accessory fissure. Okay. What is this guy?
phrenic nerve.
That is the pleural reflection right over the phrenic nerve. Major fissure is out here. It's more anterior. Okay. That is the pleural reflection over the phrenic nerve. So we can see that on a CT, pleural reflection over the phrenic nerve. On the right side, it's related to the IVC. There it is on the right side. Here it is on the left side. Okay. Now, the pulmonary ligaments are related to the esophagus. So that's the pulmonary ligament there on this side. Here it is on the other side. Related to the IVC is the pleural reflection over the phrenic nerve. There it is on the right. There it is on the left. What is the arrow pointing to?
The trigonum.
Trigonum parietale. Right. This patient has
Nasogus.
an azygous fissure with an azygous lobe. This guy down here is the azygous vein, right? So how many layers of pleura are in this? No,
4.
4. They are 2 visceral layers and 2 parietal layers. So how does this occur? Why does this variant occur?
Something congenital.
That is correct. That is correct. It's congenital. So what happens in embryology is that the azygous vein usually starts up here higher, and then as the lung grows, it slides down in the right paratracheal region and winds up in its normal location. If for some reason it's laterally located, as the lung grows, it winds up cutting through the lung, and so it drags down these extra layers of pleura with it. And so usually the azygous vein never gets to its normal anatomic location. It kind of winds up short. And then you have, this is also called the mesoazygous, like mesentery. It wraps around the azygous vein. And so this has 4 layers of pleura. Up here, you might have some fat, some extrapleural fat that gets into the azygous fissure, right? And there's a term for that because it's trigonal. That's called the trigonum parietale, right? So azygous fissure, azygous lobe. Here's your azygous vein. It's at the bottom of the fissure. And on CT, you can see the azygous fissure here. At the bottom of the fissure, we have the azygous vein. So here it is on the coronal image, azygous fissure there, azygous lobe here, and then here is the azygous vein at the bottom of the azygous fissure. Okay? This guy is?
Anterior.
That is the anterior junction line, yes. So that is below the clavicles, comes down anteriorly. It disappears where the heart is because the heart sits in the middle there. So this is where the pleura meet anteriorly. That is the anterior junction line. So here it is where the pleura meets anteriorly. Coming down, you have the heart, so it disappears. So here it is on this coronal CT image. That is the anterior junction line. This patient, we can see the anterior junction line here is shifted. So why is the anterior junction line shifted in this case?
Right, middle lobe atelectasis.
Yes, how do you know that that's right middle lobe atelectasis?
The lateral, the opacity.
Yes, so we're losing the right heart border here, and on the lateral view, we see this opacity, this triangular opacity superimposed on the heart. So this is somebody with right middle lobe atelectasis and some shifting there of the anterior junction line. This guy over here is posterior junction line, right. This patient, you can see the anterior junction line. Here's the posterior junction line. So the posterior junction line usually extends above the clavicle, comes down, disappears where the aortic knob is. This is where the lungs meet posteriorly, right? So that is the posterior junction line. Here it is here. This is where the lungs meet posteriorly. That is the posterior junction line, okay? This guy over here is
Right paratracheal.
right paratracheal stripe. The thickness is,
Normal.
yeah, it should be less than 4, right? 2 millimeters is about what we usually see. Notice that on a good PHS X-ray, you can see that through the shadow of the superior vena cava, and then here is the azygous vein over there, okay? So that is the right paratracheal stripe. So we see that because there's air inside the trachea, there's air in the lung, so it outlines the right wall of the trachea, so we see this as the right paratracheal stripe. Okay? Now, this patient, the old film, has a normal right paratracheal stripe. On the new film, we see all of that stuff. There's widening there, there's its right paratracheal opacity. What is the most common cause of widening of the right paratracheal stripe? It would be lymphadenopathy, yes. So this patient has right paratracheal lymphadenopathy, okay? Sometimes if there happens to be lung tissue there, you might see the left paratracheal line, but it's nowhere near as common as the right paratracheal line. So one of our favorite games in chest is where is the mass? So where is the mass? First of all, on the chest radiograph,
Left above the
yeah,
clavicle.
so up here, here's the mass, right? So is this mass anterior or posteriorly located?
Close.
How do we know? What do we call the cervical thoracic sign, right? So if we can see the lateral border clearly above the clavicle, it means that the mass is interfacing with lung tissue, that there's air out here, so it must be a posterior structure. So this then has to be posteriorly located in the posterior mediastinum, and if we're dealing with posterior mediastinal masses, we start our differential with
Neural.
neurogenic lesions, right. This was a neurofibroma, okay? So that's a posterior mediastinal mass. In this case, that was a neurofibroma. On the other hand, in this case, we lose the lateral border as we go above the clavicle, so where is this located?
Anterior.
Anterior. This is blending in with the soft tissues of the neck, so this is an anterior mass, okay? Again, an example of the cervical thoracic sign. What do we think this represents?
One thymoma.
Well, no, not thymoma.
Sorry,
We don't
sorry.
want to say that. It's too high for a thymoma. What did we say?
Thyroid.
Thyroid. Why thyroid? What other finding is there? The trachea is deviated, yes. If you have an inlet lesion here, right paratracheal opacity, inlet lesion with deviation of the trachea, we always consider thyroid masses first, right? So that is a thyroid goiter, enlargement of the right lobe of the thyroid. That is giving you that. So these are examples of the cervical thoracic sign. So if we can see the lateral border above the clavicle, we think posterior. If the lateral border disappears above the clavicle, we think anterior. So for a thyroid lesion, disappears when you go above the clavicle. There it is there. For this thing in the posterior mediastinum, you can see the lateral border very clearly above the clavicle. That's posteriorly located, interfacing with lung tissue. Okay? This guy is
Aortopulmonary.
aorticopulmonary reflection. So this is the reflection of the pleura along the anterior mediastinum. All right, so that's along the anterior mediastinum. So it's the reflection of the pleura here. So what lives in here? What organ? What organ? Thymus, right. So the residual of that will be the fat, right, when you get fatty involution, but the thymus lives there, okay? The aortopulmonary window, so between the aorta and the left pulmonary artery, there's this little area here that can go in towards the mediastinum. So this may be concave towards the mediastinum or straight. It should never be convex. There should never be anything bulging out of the aortopulmonary window. So that is the space between the undersurface of the aortic arch and the left pulmonary artery. That's the aortopulmonary window. If there's something bulging out from there, we think lymphadenopathy, right? Aortopulmonary window lymphadenopathy. So here's the aortopulmonary window in here, and this is the aortopulmonary reflection here over the anterior mediastinum. Right? The AP window here on the axial view, here it is on this coronal reformat. That space between the undersurface of the aorta and the left pulmonary artery is the aortopulmonary window. So in this patient, if we look in the AP window, we notice big mass. So what do you think that is? Lymphadenopathy. What else do we see on this patient?
Masses all over.
Bilateral lung nodules. What do we think is going on with this patient?
Lung cancer with mets.
So metastatic disease, right? So we look at these images, right? So here's adenopathy in the AP window. There's also lymphadenopathy here in the precarinal region. By the way, what do you notice about these nodes? What's kind of markedly enhancing? So now you should be able to give me a differential for enhancing lymph nodes. What could do that?
Vascular stuff like popular thyroid.
So vascular metastases, right? So what are the tumors that give you vascular metastases?
Choreo, papillary thyroid.
Yeah, thyroid tumors, right?
breast, lung, melanoma.
Not so much lung, renal cell cancer, right? Can give you that melanoma, is also in that list. Islet cell tumors can do it, can give you vascular metastases, okay? Now, in this particular case, there's another finding that's illustrated that should help provide the diagnosis. What's the other finding?
Looks like the thyroid's gone.
The thyroid is missing, so how do you put the story together?
Metastatic thyroid.
Yeah, this patient had a thyroidectomy for thyroid cancer, and this is metastatic thyroid cancer, okay, with bulging in the AP window. Again, what sign is demonstrated here when we play Where is the Mass?
We lose the heart.
This is the hilum overlay sign, right. You can see the left pulmonary artery through the mass. So that means that the mass is not in contact with the pulmonary artery. So it could be anterior or posterior. So which is it? Is it anterior or posterior? How do we know it's anterior? The heart border is obscured, so that suggests that this is an anterior mass. We can see the descending thoracic aorta and the aortic knob. Those are posterior structures. So here we think anterior mass, big anterior mass here, big mass in the anterior mediastinum. What do we think this is?
Thymoma.
Thymoma. This was a thymoma, yes, in this patient. Now in this case, again, we have a mass here in the AP window, but here we can't see the left pulmonary artery. So this is lymphadenopathy in the AP window, in the hilum, also extending to the hilum, obscuring the left pulmonary artery. So here you don't have a hilum overlay sign. Right? There's also right paratracheal lymphadenopathy. This is a patient with small cell lung cancer. So we have all this lymphadenopathy here from the AP window extending to the left hilum that obscures the left pulmonary artery. Okay? This line is? That is the azigoesophageal line, right? So this is the border of the pleural against the esophagus here, medially in the azygos vein, hence the azigoesophageal line. We have lung tissue that extends into this region, so that space is called the azigoesophageal recess. Right, this is the azigoesophageal recess where the lung tissue extends into there. Okay, so the azigoesophageal line travels up here, and then we have the azygos vein arching forward, so we can follow the azigoesophageal line up here, there, until we get to the azygos vein that arches forward to join the superior vena cava. So that is the azigoesophageal line. So now here, when we look at this case, this border over here is, that is the right atrium. What line then is deviated out to the right here? That is the azigoesophageal line. Now, looking at this now, you should be able to provide a specific diagnosis for this case. Why? So this is achalasia because this represents what? A dilated esophagus. In achalasia, when the esophagus dilates, it flops over towards the right. So this is a dilated esophagus causing the azigoesophageal line here to bulge over towards the right. So it can be sneaky, achalasia can be sneaky there on your frontal radiograph as the esophagus dilates and flops toward the right side. The pleural esophageal stripes, if there's air in the esophagus, we can see the walls outlined with air because there could be air within the lung on the other side, and that outlines the esophageal walls if there happens to be some air within the esophagus. Here is the esophageal recess. Sometimes some lung tissue can sneak in anterior to the descending aorta, and that gives you the pre-aortic recess. That's this area over here. That's the pre-aortic recess. So sometimes that can get confusing. So here is the descending thoracic aorta here. This line over here is, no, that's not the aorta. The aorta is here. Out here is the aorta. This is, well, these are the vertebrae. This is the left paraspinal line. There's an extra line here. And that line, in this case, is caused by this pre-aortic recess. So if lung tissue gets in anterior to the aorta, you can have this extra line that's kind of medial to the descending thoracic aorta. Between that and the paraspinal line, that is the pre-aortic recess. Okay. This guy is
Right.
right
Left, yeah, right
paraspinal line.
paraspinal.
Right, right paraspinal line. What compartment is that? Posterior mediastinum. Right. So that's the right paravertebral line or the right paraspinal line. We have a right paraspinal line. We have a left paraspinal line. Okay. So here's our left paraspinal line. Here's the descending thoracic aorta. So descending thoracic aorta, medial to that, we have the left paraspinal or paravertebral line. Notice that the descending aorta gives you a negative Mach effect. It looks like there's a lucency adjacent to it. Notice that the paraspinal line gives you a positive Mach effect. It looks like there's a little bit of an extra white line kind of tracing that left paraspinal line. And so for these Mach effects and what causes them, I would refer you to this very nice article that explains them. But the descending thoracic aorta has a negative Mach effect. The paraspinal line has a positive Mach effect. But it's a very nice article. I refer you to that. Okay. Now in this case, what line is deviated?
The left paraspinal.
Yeah, the left paraspinal line. This line is the aorta, right? So it's the left paraspinal line going out past that. So we think what compartment?
Posterior.
Posterior mediastinum. When we deal with posterior mediastinal masses, we start with neurogenic tumors. That was a neurofibroma. Okay. So let's move on to the lateral view, the things that we need to know. So here on the lateral view, this guy over here, this guy is what?
It's like the main and the right together.
Main and right pulmonary artery that are superimposed on the lateral view. That's called the right hilar vascular complex because there can also be some veins over there, but most of it is the main and the right pulmonary artery that are superimposed on the lateral view. This round lucency is left upper lobe bronchus, right. Above, or can be the left main bronchus in some patients, it depends on the anatomy. There's this comma-shaped structure here, outlined in yellow, that goes up and over the left upper lobe bronchus. What is this guy?
Left.
That is the left pulmonary artery, right, going up and over that. And then over here, this one's easy. This is the, yeah, that's the arch of the aorta there, okay? So that's what we see on the lateral view. Another example showing you the same thing, right hilar vascular complex, comma-shaped structure going left pulmonary artery going up and over the left upper lobe bronchus, and then here is the aortic arch. So this is, you should be able to make out very nicely on a good lateral view. The anterior border is made up by right ventricle and pulmonary outflow tract. The posterior border of the heart, the upper border is, what makes up the upper border?
Atrium.
Left atrium. Lower border is left ventricle. This guy over here is IVC, right, that's the inferior vena cava on the lateral view. This guy over here is, that's the left upper lobe bronchus. This guy is
Right.
right upper lobe bronchus. Yes, sometimes you can see the right upper lobe bronchus on the lateral view. It's usually superior to the left upper lobe bronchus. All right. Now, the left upper lobe bronchus is surrounded by vascular structures. We have the hilar vascular complex. We have the left pulmonary artery going up and over it, over the left upper lobe bronchus. But down here, there's a relatively clear area here. That is called the infrahilar window. All right. This line is,
Tracheoesophageal.
no, that is the posterior wall of the bronchus intermedius. The trachea is up higher. Right? That's the posterior wall of the bronchus intermedius. So on a well-taken lateral view, that will bisect the left upper lobe bronchus on a well-taken lateral view, posterior wall bronchus intermedius. We see that because there's air here in the lung, and then the posterior wall here projects over the left upper lobe bronchus, and that's what we see on the lateral chest radiograph, posterior wall of the bronchus intermedius. The infrahilar window is this relatively clear area here, left upper lobe bronchus, right hilar vascular complex, which is main and right pulmonary artery. Left pulmonary artery goes up and over the left upper lobe bronchus, but this area is relatively clear. So normal infrahilar window here. This guy right here, what am I pointing to? What is this guy?
The anterior wall of the left
You're almost there?
intermediate.
No.
No, the left inferior bronchus.
Left lower lobe bronchus. That is the anterior wall, that's the anterior wall of the left lower lobe bronchus. Okay. Here's the left upper lobe bronchus, right? So then you have left lower lobe bronchus. Now I talk about the bite out of the donut. So you have left upper lobe bronchus, you have the hilar structures going around it. Normally it looks like there's a bite here, there's a clear area here. That's normal. So you should not see a complete donut. If you see a complete donut, we call it the donut sign, and that usually implies subcarinal mass or subcarinal lymphadenopathy. So subcarinal lymphadenopathy in this patient with some tumor here, so that gives you a complete donut. Here's a patient with sarcoid who has right paratracheal nodes, some hilar fullness, some hilar nodes. On the lateral view, we notice a complete donut, so that means that there has to be subcarinal lymphadenopathy in this patient. So complete donut sign, think subcarinal mass or lymphadenopathy, if we see that on the lateral chest radiograph. So in our patient with sarcoid, we have the right paratracheal nodes, subcarinal nodes here, also some hilar nodes, more subcarinal nodes. So that's the subcarinal nodes gives you the donut sign on the lateral chest radiograph. This line is the, yeah, so that's the posterior wall of the trachea. So that's the retrotracheal stripe. Okay, so the retrotracheal stripe, we see that because some air can get from the lung can get posterior to the trachea there, and we'll see that as a stripe. Notice in this patient, it is thickened. What do we think about? Yeah, the esophagus lives back here, so what could that something be in the esophagus? Or cancer. Yeah, this is a patient with esophageal cancer. Now, you senior residents should also tell me another finding here on this axial CT cut. What's the other finding that this patient had?
In the right.
Pneumonia?
Yeah, this is a contained perforation. So this is an esophageal cancer with a contained perforation here. There's all this air and debris to the right of the esophageal cancer. Okay. We said the anterior border is the right heart border or the right ventricle going into the pulmonary outflow tract. So here's a patient with tremendous enlargement of the pulmonary arteries, patient with pulmonary artery hypertension. So here on the lateral view, this is the aorta. This is enlargement of the outflow tract and the main pulmonary artery, and this is the left pulmonary artery, really big. Here's the main and right pulmonary artery there, projecting laterally. Big pulmonary arteries, big right ventricle. The reason for the pulmonary hypertension is, what's the reason for the pulmonary hypertension? COPD, emphysema, yes. This patient with emphysema. And so here in this volume render view, you can see the correlate. So the enlargement here is the outflow tract right ventricle going to pulmonary artery, and then here's the aorta superimposed on that. Main and left pulmonary artery gives you that big opacity on the lateral view. Okay. So heart looks enlarged here. Why is the heart enlarged in this patient?
Fusion.
What's the sign of a pericardial effusion?
The Oreo sign.
The Oreo sign or the sandwich sign on the lateral chest radiograph.
Wait, what's the Oreo sign? Sorry.
Oreo, like Oreo cookie, the Oreo cookie sign,
It's really good.
or the
Oh,
sandwich
like the
sign.
fat and the-
Yeah, so let's talk about it. What is this? This lucency here is what?
Epicardial.
That's epicardial fat. This lucency out here, mediastinal fat. The area in between,
The fluid.
that's the pericardial fluid, right? So that's how we get the sandwich sign on the lateral chest radiograph. So that finding on the lateral chest radiograph is a finding of a pericardial effusion. Now, in some cases, you can actually see the pericardium if there's enough fat. The normal pericardium, very thin. Here's epicardial fat. Here's mediastinal fat. That very thin line is the normal pericardium in this particular case. If there's pericardial fluid on the lateral view, sometimes we will have the sandwich sign as that fills with pericardial fluid, giving you thickening of the pericardial stripe on the lateral chest radiograph. This guy here is SVC, that is the superior vena cava. This guy here is IVC, that is the inferior vena cava, right. There are three relatively clear spaces on the lateral chest radiograph. This is retrosternal, this is retrocardiac. There's a triangle here that is called Rader's triangle, or the retrotracheal triangle. The borders of Rader's triangle, the anterior border is the trachea, the posterior border is the spine, right, the anterior border of the vertebral bodies, and the inferior border is the aorta, right. So those make up the borders of Rader's triangle, okay? So in this case, when we look at those spaces, which one is abnormal?
Retrosternal.
Retrosternal, right. So we're thinking what compartment?
Anterior
Anterior mediastinal mass this patient has. There it is, an anterior mediastinal mass. What do you think that is? Thymoma, right. That is the thymoma in this case. Okay. Now, which one of those spaces there on the lateral chest radiograph is filled in? Rader's triangle. There's an opacity here in Rader's triangle. Notice also that the trachea smoothly kind of pushed anteriorly, that smooth contour of the trachea. So that makes you think what?
Aberrant.
Aberrant what?
Subclavian artery.
Aberrant right subclavian artery. Yeah, an aberrant subclavian artery gives you that smooth indentation in the trachea, and it can give you an opacity in Rader's triangle. So this patient has a left-sided arch with an aberrant right subclavian artery. As it goes across behind the trachea and the esophagus, it gives you that smooth indentation along the posterior wall of the esophagus, and gives you an opacity there in Rader's triangle. Okay? So, don't think too hard on this one. This patient has fever and cough.
Pneumonia.
Where?
In the left.
Left lower lobe, right. Here, that's the retrocardiac region. You have extra opacity there. Also, it obscures the left diaphragm. Always look for both diaphragms on the lateral view, right? If you can't see one of the diaphragms, think about why. We can see the right, can't see the left. This patient has a left lower lobe pneumonia. Old chest x-ray, you can see both diaphragms. Now that diaphragm is obscured because of the silhouette sign with pneumonia. Also have all this opacity in the retrocardiac region. Also have a nice spine sign. Normal lateral should get darker as you travel down. Here the film gets whiter because there's pneumonia there in the lower lobe. Okay? So on the frontal views, you can compare with the old chest x-ray. There's the pneumonia in the left lower lobe. Some test cases. 2 years ago, now. What looks abnormal?
Aeropulmonic reflection is the little.
Okay, so this area here is
That's also the
AP window.
Yeah.
What happens?
There's something there.
There's something there. What do we think that something is?
Maybe like a lymph node.
Lymphadenopathy. There is lymphadenopathy in the AP window. What's the diagnosis? No.
Could be that.
That's
You can do better. The answer is on the image.
Oh, there's bronchogenic.
Yeah, there's a tumor here. So it's bronchogenic cancer. What cell type?
Probably
Squamous cell, right. Squamous cell cancer of the bronchus, left upper lobe bronchus here with metastatic nodes to the mediastinum. What are these small nodular opacities?
The collapsed bronchi, like the train bug.
Yeah, this bronchiolitis from obstruction of the airway. There's some bronchiolitis there in this case. Okay. So here, what's abnormal?
left spinal.
Oh, the left paraspinal.
So that's hilar hernia.
There's a retrocardiac opacity, right? See it? There it is on the lateral view. Looks like there's air in it.
So
Could be a
hilar
cavitary lesion, but the most common cause of retrocardiac opacity with air is
hilar hernia.
hiatal hernia. That is a hiatal hernia, yes. Okay. A little more subtle. Anybody see the abnormality?
Yeah, feel the carina.
Yes. So underneath the carina, there's a little something here. The lateral view may be donut sign, little tough, pretty subtle. Here's the CT, pre-post. coronal view, there's no enhancement in this lesion. What is it?
Isn't that like a
Bronchogenic cyst, yes. Subcarinal location is the most common location for a bronchogenic cyst. That is a bronchogenic cyst. Okay. This patient has fever and back pain. What's abnormal?
Right paraspinal.
Yes. So here, this line is esophageal. This line is right heart border, right? That's the right atrium. This line is the paraspinal line that is bulged. So what compartment? Posterior mediastinum, fever, back pain. What are you thinking about?
Abscess.
Paraspinal abscess. We consult
Neurosurgery.
neurosurgery, right? This patient has a paraspinal abscess from discitis and osteomyelitis affecting the vertebral bodies. So here you consult neurosurgery. So what sign is demonstrated here?
The
Hilum overlay. Yes, you can see the pulmonary artery through the mass. Is this anterior or posterior?
posterior. Wait, no.
Anterior.
How do you know it's anterior?
Right.
Yes, we lose the right heart border. So this is an anterior mass.
Yeah.
Okay, hilum overlay sign. We can see the pulmonary artery through the mass. Here it is on CT. What could this be?
Lipo something.
So liposarcoma, right? It's mostly fatty, so it could be a liposarcoma. What else would be in a differential? Thymolipoma, right. Thymolipoma, big fatty lesion of the thymus, is also in the differential diagnosis. This was a liposarcoma, all right? That was a liposarcoma.
Wait, and how do we distinguish between both of them?
You can't. That's why
Just biopsy?
unless you have old films that shows no change in 10 years, that they usually remove thymolipomas usually get removed. But a little bit of soft tissue within the lesion, consistent with both thymolipoma or low-grade liposarcoma. Okay. Where's the mass?
In the posterior.
Because of the
Thoracic.
cervical thoracic sign, and so we start with neurogenic tumors. That was a neurofibroma. Okay, so there will be a quiz on this material next time. And thank you for your attention. See you guys in a couple of weeks.
This freaking